Actually, this topic was given to some other doctor, and she was not able to come. The reason is, and I will try to present as simple as possible. All of us know that we have got one thing called visual axis. That is a line connecting the object, passing through the nodal point. The nodal point is where in the lens, posterior part of the lens, and goes to my fovea. That's called visual axis. Object, nodal point, fovea. This line is called visual axis. Right eye has got one, left eye has got one. So note this visual axis should maintain some equilibrium. If the alignment is deranged, it is called squint. That's all. If the alignment between the visual axis of both, either the physiological relation is not maintained, it is called squint. Squint can be of so many reasons. I'll tell you one thing. Now, afferent pathway from refractive errors, cornea, opacity, like you can have macular problems, optic nerve problem, that is going on up to the brain. That's called sensory problems. So anything affecting your sensations, reaching your brain, you will develop squint. Please remember, this is called concomitant squint. What is that? Sensitive problems. Here, what's the beauty now? The efferent pathway is normal. The movements are normal. That means what's the classical difference now? Diplopia may not be there in these patients. Diplopia may not be there in these patients. Of course, rare exception is there, but usually, whereas efferent pathway is involved, a paralytic is called incomitant squint or paralytic squint. The muscles are paralyzed. That movements are problem. They will experience diplopia. Understand now? To overcome diplopia, they will have hip postures. Adaptation of hip postures and all. That means what? When you see a person is having hip posture and is having squint, think about the problem maybe in paralytic squint. It's not concomitant. Very rarely you can have. Like so many things are that different. But usually these are normal things. Understand now? What I told you. What is crooked now? What is a squint? Misalignment of visual axis. Misalignment of visual axis. That is a physiological relation is not maintained. See, I can have convergence. I cannot divergence. So many things. But they have to maintain some relation. If it's altered, it becomes squint. Understand now? I already told you, concomitant mode, the sensory pathway is a problem. Sensations reaching my brain is problem. That's called sensory. Here we got tropias. When I see the person is having squint, man, right eye is deviate out. Left eye, like, no, from outside. But when you see now, when you see the person is having no squint, eyes are normal. When you cover one eye, that means the impulse from the eye is not reaching my brain. So the right eye brain impulse goes to my brain, left eye impulse goes to my brain. They are fusion. So when the fusion is prevented by covering one eye, under the cover, this eye may deviate. When I uncover, again the eyes become straight. That is called phorias. That is called phorias, latent squint. That means you are bringing out the squint out by putting a cover test, that's all. There are so many tests for that. Just know this. Cover test is mainly to bring out the squint. That is 4 years. And of course, other things also, trophy also you can find out. But mainly to bring out the 4 years, we have to do something, alternate cover, whatever thing is there, you have to do this. Chief complaint what patient will come to you what diminished vision. You know, diplopia is there, patient will come and tell you, sir, I am loss of vision. Tell them because they are not aware. They will have false images there. They will think, sir, right eye for diminished vision, they will tell you. So you have to be very careful in that case. Head posture, I told you. By seeing the head posture, you can know which muscle is involved. Very easily you can tell in the exams. Suppose the right eye, for example, I want an example tell you. Only one muscle you will be asked in the exams. Only one muscle. A normal examiner should ask you. Normal examiner, please remember this. That means superior oblique. Superior oblique is the only muscle which is supplied with single nerve. There are 3 different actions and the 3 different postures. Superior is what? Oblique is what? Depressed or chin is depressed. But the tilt and turn, please never forget in superior oblique is always towards sound side. But suppose right to superior oblique problem is there, head is tilted towards the left side. Head is turned towards the left side. That is the only thing you are supposed to remember. Don't bother about other muscles. You'll get confused. But most important, of course, lateral rectus muscle, turn to right side. That's enough. That's okay. Right or left, you know, only horizontal turn. But tilt and all these things classically can affect your vertical muscles. But most important is your oblique, superior oblique. I told you, normal examiner should ask you when superior oblique. Okay, you tell the examiner straight away. Okay. Devolution, age of onset, of course, for birth problem is there. All these things, you got infant lysotropias are there. So many problems are there. Is a constant intermittent. Sometimes it can comes and go. That's what we got. Intermittent squint is there. Like that you can just see the patient and tell you. That's all. You ask the histories. Past history, classical refractive errors. The patient might be having glasses and all. Myopia patients in future may develop a problem of divergent squint. Hypermetropy patient in future may develop a problem of convergent squint because of excessive accommodation. Because hypermetropes cannot see distance and near simultaneously. Because we cannot see both. That's the problem. Is using accommodation always to see even to see distance. That's why his accommodation is coming into play. He will go in for convergent squint. This is what I'm supposed to know that. That's why it's defined it is a must. You ask for any history of any surgery was done for the patient. Any occlusion therapy was done. You know, these are all, any squint case, man, just a patient has come to you. You just see the visual acuity, dilate the pupil, see the fundus, and do retinoscopy. If a problem is there, if suppose visual problem is there, something is there, you do amblyopia treatment. Then you can think about giving a penalization, whatever thing is there, treatment for amblyopia. Then you can see prism test, prisms and all, you can use it. Then finally you can go for surgery. Don't tell straight away surgery. Understand now? That means what? Any case of squint comes to you, you have to tell this in the way. Dilate, see the fundus, retinoscopy, refraction, amblyopia, is there correct amblyopia? Then any prism is required, you can give prisms, glasses can be given. Understand now? Then you can give surgery finally. You have understood? Always see the family members. Suppose surgery is done, see the family members. Family members may be having squint. You do not know. And they might have done surgery for him. The surgery may be successful or not. We do not know. That's why always remember, you have to examine a person, a squint, always examine the family members. Family history. I already told you, 8 postures and all. Remember? Facial symmetry, ptosis. Examinations, never forget visual acuity. Never forget visual acuity, I told you. Hirschberg test, everyone knows that. See now, the light is falling on the pupil margin means you are normally 15 degrees. Away 25, then 30. But here, one tricky question will ask you in exams. What is the diameter of the pupil will ask you. Suppose you tell the diameter of the pupil 3. Now the light is reflected in the falling in the pupillary margin. It cannot be 15. See, 1 millimeter only 7 degrees. If it is from center to margin of the pupil 1.5, if 3 means 1.5 only. 1.5, 1 to 7, how much? It will be only 10 or something. So always never go to confusion. That means always people in the margin is 40. It's not 50. It depends upon the size of the pupil you are supposed to tell in the exams. Hirschberg test and all. Cover test. Always remember, cover test, alternate cover test and all you are supposed to practice. What's happening to the uncovered eye, what's happening when you remove the cover, what's happening to the eye under the cover. Like that, all these things you can just, in 10 minutes is impossible, but squint you have to take at least 1 week. Then only you can take proper classes. Then only you will understand what is squint. Otherwise you will run away. Hello. You will run away from squint. Just know, never forget about this. These are all the various things. Krimsky means what? I'll tell you. Krimsky tell me you are putting prism, man, to find out how much of deviation is there. But Krimsky means you are putting prism in front of the deviated eye. Suppose I'm having esotropia is there, your apex always iso. That means base out. Apex to be always seeing the deviation, base out. You are going to find out. So Krimsky is what? Putting the prism in front of the deviated eye. What is modified Krimsky means? You are putting the prism in front of normal eye. Okay, keep on increasing the power so that other abnormal eye will become straight. This is what modified Krimsky is. Krimsky I told you, modified Krimsky I told you, remember? 4 years. Say any case I told 4 years to find out 4 years for near. If I got one test called Maddox wing. Maddox rod with a tangent scale is there. That is for squint. Fovea is there for distance or not. Very simple, man. Suppose, in this case, right eye sees from right side hole and the right side will see only the arrow. Left eye will see the numbers. Imagine you are a normal person, you will see the arrow and zero in same area. Suppose my right eye is deviated somewhere, that means, please remember, eyes are looking straight. When you see through this test, the arrow is shifted. That means what? You are breaking the fusion by giving different pictures. Right eye seeing an arrow, left eye seeing a number, brain cannot fuse. That's why the eye is getting deviated. That's why when the arrow is coming to right eye, right side, esophoria. Left side, exophoria is going up. Always remember, when the arrow goes up, that means the right eye has not gone up. That means the right eye at lower level. Left hyperphoria. The arrow has come down. That means right eye has not come down. Left eye has gone down. That means the right eye higher level. Like very easy to remember. Understand now? Very easy. The eye has not gone there. Finished like this. Remember like this. But never forget, patient, don't tell right eye esophoria. Left eye, don't tell. You tell patient is having esophoria. Finished. Patient is having, same thing can happen with the left eye also. We do not know. So that's why I always tell esophagus like this. And never forget you do dip by charting. You understand now? All these things. And you have got, whether the patient has got adaptation, sensory adaptation is there for squint, like abdominal written correspondence. Sensory adaptations are there in the patient. You have to find out. There are so many tests for that. What 4-dot test? So many tests are there. That means you have to find out abnormal little correspondence is there or not in the patient. This is the one most important thing. This is what 4-dot test you can use it. Then we got other after image tests. So many tests are there for abnormal correspondence. These are all very simple things, but once you go and read, it's a very easy things. Understand now? One of the easiest subjects. Again, I tell you, Squint. My advice to the students, never bother about examinations. Don't bother. Go inside. Hello, with a clear mind. Okay, examine the person, see the signs, write it, present. Don't bother about diagnosis. Don't take any clue from anyone in the hall. Don't take any clue. If you take a clue, you are finished. Because your mind will be misguided there. You'll be keep on thinking the same thing. Suppose I tell you, is a case of papilledema is there, you go and see the patient is not having papilledema. You think what is the case of papilledema, you keep on telling papilledema in the exams. I've seen students telling like this. How to follow? So take your own time.